All right, thank you so much. We want to welcome everybody, and thank you all very much for joining us. As Steve said, my name is Ajita Prabhu, and we wanted to welcome all of you to our program tonight. We're going to be talking about emergent ventral hernia repair, and there are over 900 registrants from more than 70 countries around the world who are going to be participating at some point, whether it's now or asynchronously in tonight's program. So we're super excited to welcome you all. Next slide, please. With that, we want to take a moment to acknowledge our partners in this, including Cook Medical, Johnson & Johnson, and Medtronic, and we want to thank them for providing partial educational grants to support this program. Tonight's program is brought to you by, next slide, please, myself and Dr. Ben Miller, who's going to be our moderator. Ben is an expert in abdominal wall reconstruction and is the enterprise-wide division chief for the Division of Emergency General Surgery. So he and Dr. Pena and Dr. Testaldi are going to talk to us about emergent ventral hernia repair and management strategies for that. We sincerely hope you enjoy our program, and thank you again for joining us. And with that, I'm going to turn it over to Dr. Miller.
Thank you, Dr. Prabhu. Thanks, everyone, for joining us this evening. This is a really exciting webinar. Like Dr. Prabhu said, I am the Enterprise Director for Emergency General Surgery, but I also, in my elective practice, do hernia repairs. So this is like the perfect marriage of emergency and hernia repairs. So we have some exciting topics for you tonight. Dr. Ana Pena is from Cleveland Clinic, Florida. She's a bariatric and MIS surgeon there. She's going to be talking to us about parastomal hernias. Dr. Luciano Testaldi is a hernia and MIS surgeon here at the Cleveland Clinic with us, and he's going to be talking about whether or not to stage a hernia and come back later for a more durable repair, or if you under which circumstances you consider doing a more definitive kind of complex operation in an emergency situation if that's indicated. So the title of this is Emergency Ventral Hernia Repairs. Do you go for a base hit or swing for the fences? And by that, I just mean when you're confronted with a ventral hernia in an emergency situation, do you do what's necessary to get out of Dodge, or do you do a more complex, more definitive type repair if the situation permits? So I'm excited to hear what our presenters have, and we'll kick it off with Dr. Pena.
Hi, good afternoon, everyone. Thank you, Ben. I'm going to share my slides here. So today I'll be talking about parastomal hernia repair, and we all can identify these hernias, and the problem comes when we have to decide whether to actually do surgery or no surgery. If we do surgery, what kind of surgery do we have to do? And I have nothing to disclose. So parastomal hernias are a very long-term complication after stomach creation, and there is a very high incidence, as high as 70% with end colostomies. And many times patients are asymptomatic. Sometimes we find them on the imaging modality, but sometimes they can have emergency complications, obstruction, strangulation. Unfortunately, there are many risk factors that are patient-related, which we as surgeons cannot control. And there are some other factors that we have some control of, but there are no definitive guidelines as to how to do them. And there is a lot of technical variability, such as making a smaller aperture when we create these stomas initially, making sure that we pass the stoma through the rectus abdominis muscle. And there are some that we cannot change, what is the case of the end colostomy. The parastomal hernias have been classified based on different systems. One of them depends on the location of where the herniation is, whether it is interstitial between the muscle layers, subcutaneous in the subcutaneous space, peristomal adjacent to the stoma, or intrastomal, which is when they present as prolapse. And also the European Hernia Society has classified them given the size of the defect and whether or not they are, there is a concomitant incisional hernia. Because one thing is a patient with a parastomal hernia and a completely different thing is a patient with a parastomal hernia and a concomitant incisional hernia, and it would change completely the surgical approach. Majority of the times we identify these hernias clinically, but in my case, when I'm planning for a reconstruction, I always want to get a CT scan. I want to see more details about the defect size, the contents, and in the case of emergency surgery, many times we already see these patients after they've already had the CT scan in the emergency room. So the first question is, can we prevent these hernias? And there have been some studies that have shown a decrease in the incidence of parastomal hernias when we use prophylactic mesh with a good 40% relative reduction. However, when the more modern or contemporary randomized controlled trials were analyzed, there was no statistically significant benefit. At least these reviews show no increase in morbidity, mortality, or length of stay using the prophylactic mesh. So in my mind, is it safe to do it? Probably. Is it effective? Overall, the evidence says yes, but we still need more studies to better decide. So if I had to reduce my whole talk to one slide, this would be the slide. Basically, if we cannot prevent it and now the patient has a hernia, do we have to fix it? Well, patients that are asymptomatic, my approach is always to observe them and do a lot of ostomy nurses care to optimize the pouching and take care of the skin around it. Now, if the patient is presenting with symptoms or presents with an obstruction, incarceration, risk for strangulation, definitely this patient needs to go to the OR. Now, the question is, now we decided the patient needs to go to the OR, what is the approach? What am I going to do? Definitely in my practice, I would avoid primary suture repair because that has shown a very high recurrence rate. So my approach will always be a mesh-based reconstruction, and we will see the different types of mesh repair. So if we decide, we can observe, we can reverse the stoma. That would be the ideal situation, but unfortunately, it's not applicable for all patients. Another option would be to relocate that stoma to the other side, and that might seem appealing, but unfortunately, we are creating now two different holes. And the other option for treatment would be repair. And here we can talk about different options, whether intra-abdominal or subcutaneous, open or laparoscopic. Observation there is low risk of complications for these patients. And if we operate later, there have been similar results as operating early. Relocation, unfortunately, has still a very high incidence and also has a very high incidence of hernia at the previous ostomy site. Laparoscopic versus open, these observational studies have shown, like for most minimal invasive surgery, shorter OR time, shorter length of stay, lower morbidity, and lower surgical site infections rate. Now, between the options to operate, one important distinction is where do we want to place the mesh. So the retromuscular options, whether it is open or robotic, give us the ability to place that mesh in the Sugar-Baker configuration in a plane outside of the intra-abdominal or intraperitoneal cavity where it's away from the mesh. But it can cause sometimes angulate the stomach too much and can cause obstruction, but it's definitely a good plane for the mesh placement. The keyhole technique, we have to create a hole. So by doing this, we already are kind of weakening the mesh, and if that opening is too wide, that increases the risk of the hernia coming back. Also, if we make it too small, then it can increase the risk of stenosis or erosion. And it has a very high recurrence rate of 37%. Now, Sugar-Baker repair, here this is my preferred approach, and this is an older case, but basically we do the lateralization of the bowel and then place the mesh, and it has a lower recurrence rate. So in my practice and in my preference, I would always try to do the sugar baker repair because it has shown some lower recurrence rate. There are less chances of stenosis, and it would be my go-to. There have been multiple systematic review studies that have shown the decreased recurrence with sugar baker compared to keyhole. However, we also have to keep in mind that more modern studies have also not shown such a significant difference between the two. So I don't think the discussion between sugar baker versus keyhole is completely finished. So where is the field going? We have other, besides the laparoscopic sugar baker or the keyhole, now the robotic sugar baker is an option as well, and it makes it easier for us to suture. And the robotic poly, where we place the mesh in that retromuscular space, has been showing very good midterm results, but we still have to continue to study, but it seems to be very good for the future of complex parastomal hernia repairs. We always have the open retromuscular option, and then TAR, that I would not do it unless we have to do it for abdominal, it's needed for the abdominal wall reconstruction, but I would not perform it just for to fix the parastomal hernia. So my algorithm, if the hernia is small, I would do a laparoscopic or robotic sugar baker. If it is a large parastomal hernia plus an incisional midline hernia, my approach would be a retromuscular repair plus or minus TAR. If it is a recurrent after a previous IPOM repair, then that would be a robotic poly. And if it's a hostile abdomen, I would go for an open reconstruction. So, and all in all, I think repair is better than relocation. Intra-abdominal repair superior to subcutaneous. Sugar baker seems better than keyhole, and laparoscopy better than open. If I'm performing an abdominal wall reconstruction, then definitely retromuscular repair probably better. And prophylactic mesh has been showing less recurrences, but additional data is still needed.
All right, thank you, Anna. So we have some questions coming in, which is great. We're gonna wait. We're gonna have like a Q&A after all three presenters get through their talks, just briefly, and then we'll move to some cases toward the end of the hour here. So we're gonna hold questions for now. We'll come back to you, Dr. Pena, but Dr. Castaldi, you're up next.
I'm responsible for the next talk. Shifting a little bit of the focus, I'm going to be talking about emergency ventral hernia repair. And I'm happy that some questions about this topic is already popping up on the chat. We're going to try to tackle those as we go. I don't have any disclosures related to this talk. And this is like a very typical situation for all of us general surgeon. It sometimes happens at 2 in the morning. And a patient with sometimes a small hernia or a multiply large recurrent hernia shows up with an incarceration and an episode of obstruction, and we are called by the ED. And this can be a pretty daunting situation, especially when we're dealing with like comorbid patients, unoptimized with very complex and hostile abdomens. Sometimes the first thought process is, am I able to take care of this here on my local resources? Do I have to do a complex abdominal wall reconstruction? Do I have the expertise for that? Or this needs to be transferred out to a more specialized center? I'm going to try to give you some insights about what are the objective factors that lead me to stage a repair, or when it's okay to try to perform some more complex definitive procedure in this scenario. And it's very common for people to think, well, if I'm going to stage all those hernias, I'm going to be a surgeon that is not really fixing the problem of the patient. He's going to be upset with me after he leaves the OR, knowing that his hernia will most likely come back, or whether I'm leaving the OR after performing complex reconstructions on all of those patients, I'm going to be feeling good about myself, but the risk for complications need to be considered, and whether we are doing actually the best for our patients. So one key important thing that I want to leave here as a message is that the goal for an emergency ventral hernia repair is not to fix the hernia. It's actually to resolve the obstruction, to save the incarcerated bowel, and provide with this patient with stable soft tissue closure. So a strategy when we're dealing in an emergency setting Staging a repair is a strategy and should never be considered a failure. And there are three main things that we need to use in our decision making to determine whether a staging is the best approach or a formal reconstruction or a more durable repair can be done at the same time, which is physiology, the field, and the abdominal wall. With regards to physiology, I think when we see a very sick patient, it's very easy to actually know that we should try to avoid doing complex procedures and formal reconstruction. A patient who presents with sepsis, who's acidotic, hypothermic, with hemodynamic instability, or with bleeding requiring transfusions should be staged most of the time. With regards to our operative field, of course, when we're dealing with gross contamination, even though we already know there's plenty of data that's saying that using macropore synthetic mesh is safe in a clean contaminated or a contaminated field, when dealing with stool spillage or purulent material on the field, we will probably lean towards staging versus providing with a formal reconstruction. And even in the absence of gross contamination, when you're dealing with a multiply reoperative field, you have to do a lot of adhesion. There was serosal tears or interotomies. This adds time, this adds morbidity to the case. Sometimes we have to do bowel anastomosis or creating an ostomy in this scenario. Those are all factors that also would make me lean more towards a staged approach versus formal reconstruction at that time. And along the same lines, the abdominal wall per se. Large hernias with loss of domain, where I look at the CAT scan or I look at the patient's abdomen and I already know, due either to the size of the defect or the visceral edema, that I know that closure of the fascia is going to be very difficult or nearly impossible without having to employ myofascial releases, for example, are also factors that I take into consideration on my decision-making to stage. So now, towards the other aspect of this talk is when it's okay to provide with definitive repair. I think this is very easy to discuss when we're dealing with smaller hernias. Patients with no systemic compromise when dealing with a clean field and facial closure is easily achievable. I think it's perfectly acceptable to provide the patient with a formal reconstruction at that time. And in my preference, either an open retromuscular sublay, like for example, a reef stopper repair, or if the patient is not very distended and I have the ability to perform this in a minimally invasive setting, my preference would be for a laparoscopic IPOM. When we are talking about the large hernias, I would have a faculty that would always say that if you try to perform a complex procedure in an emergency setting, the first thing you gotta go is look at the sky and make sure that the sky looks exactly like this. It's gotta be a perfect situation where whether you're trying to perform a complex procedure or a complex abdominal reconstruction in this setting. So the same conditions apply, no systemic compromise, a clean field, a facial closure is achievable. But I think the most important thing is that the expertise is available to you or to whoever is helping you, okay? If you're not performing complex abdominal wall reconstruction, posterior component separations on a daily basis in optimal conditions, you should not feel forced to be trying to do that either in the middle of the night or in an emergent setting in a non-optimized patient in non-ideal conditions. So how do I stage without burning the bridges, without making the next repair more difficult, without creating big complications? Meaning, how do I get out of Dodge and provide this patient with the best opportunity to recover from this acute insult? So you would be very actually surprised in how much we can close large defects just by closing them primarily with interrupted figure of 8 stitches. Sometimes that's possible, sometimes it's not. When I cannot close the fascia with figure of 8s, my next step would be to use an absorbable type of mesh to try to bridge that defect as an inlay. And by keeping the bowel inside, using that mesh to bridge the fascia, the next step is ensuring that I have stable soft tissue closure. So for those complex cases, when I decided that I'm going to stage it, there's no need for relaxing incisions, myofascial releases, skin flaps, or anything very fancy. So here's like how we usually use to close big defects. Just to be honest, this is like a video for an elective setting when we're doing a TAR for a very wide defect. We put those figure of 8 stitches of number 1 PDS. We don't tie them from the beginning. And we start tying them under tension. And this is how it looked. This was like a 23 centimeter wide defect. And we did a lot of tensiometric studies in the past. And even though this patient had a TAR, someone would argue that we're just being able to close the fascia because of the TAR. We already know the TAR does much more for the posterior sheath rather than to the anterior fascia. And what if I cannot close the fascia? As I mentioned, an absorbable type of mesh like Vicryl, that's what would be my approach. So here on this picture on the left, I have here this area of the fascia that was not able to close. I use that Vicryl mesh. I put inside the abdominal cavity. I suture that with absorbable sutures to the edges of the fascia, leave drains on top, and I ensure that the skin and the subcutaneous tissue are closed on top of those drains, with here in this scenario of interrupted vertical mattress stitches. And after that, recurrence is expected. It should not be seen as a complication. Patients should be aware that we temporize their abdominal wall, and in case the hernia recurs in the future, that's when we're going to tackle for a more durable repair. And for this comorbid patient population, this is now a great opportunity to try to tackle some preoperative optimization with smoking cessation, with weight loss, diabetes control, and the definitive repair can definitely wait. I think what we use to as the main factor to try to act faster is if those patients are having recurrent obstructive symptoms. If they're not, we can wait until we have a better local and a patient situation for the repair. So I think my take-home points is just have in mind the goal for an emergency ventral hernia repair is to resolve the obstruction to save the bowel and to ensure some stable soft tissue closure. Staging is a strategy and should not be seen as a failure. We don't need to burn any bridges when trying to do myofascial releases to close the abdomen. Just simply use a piece of Vicryl mesh, sutures to the edges of the fascia, and close the skin on top of the drains. Making it simple and safe should be the goal when we're dealing with an emergency repair. Thank you very much.
Thanks, Luciano. That was great. I'm going to jump into my talk here. Okay, so this is the second part of emergency ventral hernia repair, and it's about techniques for closing the abdomen if it's a difficult closure. And I'm going to repeat a lot of what Luciano said, so you kind of hear this twice from two different people, and you can tell how we like to run our practice here, especially in emergency situations. And one disclosure, I don't think it'll be relevant to this talk. I'm not going to really talk about any synthetic mesh. Okay, so the situations where we are often encountered with an abdomen that's difficult to close are both when patients have been left open for a day or more, and you bring them back to the operating room and the fascia is kind of retracted and there's a ton of tension on it, and they can be very difficult to get closed in these situations, or in just a massive loss of domain ventral hernia. You get in there and you free up all the bowel, and then you're left looking at this huge hole, and you're trying to figure out how to get this patient closed. So we're going to kind of go through the different techniques that are available for closure in these situations. And the first technique, like Luciano talked about, is primary fascial closure. We'll again go over how we do that and some of the data to support that. And then there are many ways to plan a ventral hernia. And like Luciano said, like this is not a failure. Planning a ventral hernia, I think, is a great way to stage this to come back at a later date when the sky is blue, you have the expertise and all the resources you need for a more definitive, complex repair. In planning a ventral hernia, there are a few different techniques you have at your disposal. You can do a skin-only closure. I don't really favor that. We'll talk about why shortly. And then you have a mesh-based repair, either using absorbable mesh or a biologic or biosynthetic type of mesh. We'll talk about these later on. And then I want to bring this up early on. I don't think that if you're having difficulty closing the abdomen, whether the abdomen has been left open or you're encountering a big hernia, I do not think that in these circumstances you should employ myofascial releases or component separation techniques to get the abdomen closed. We will sometimes get calls, people looking to transfer their patients here with a big hernia, and sometimes I'll hear, I think this patient needs myofascial releases or component separation to get the abdomen closed. And this is like this is an emergency situation where the patient has a bowel obstruction, they have an incarcerated hernia, and in those situations, we're obviously happy to take these patients on our service, but I will tell you, I do a lot of component separations, do a lot of TARs in my elective practice. I've never once done myofascial releases in an emergency setting to get a patient closed. It's just not something that I think is worth doing in the emergency setting. I don't do component separation. So I just want to sort of like, there's only one thing you hear here in this talk tonight, is that in an emergency situation, if you can't get the abdomen closed, like I would really avoid doing myofascial releases in that scenario. Like Luciano said, I think the best approach here is using primary fascial closure, and he showed you a nice video of how we do this. We put interrupted figure of 8 sutures in, and we align the suture. We put a suture in and then put another one in, and we put them opposite sides of the abdomen. And so when you have all these sutures in, one person on one side of the abdomen picks up all the sutures, and the other person on the other side picks them up, and then you can close them from the top and bottom, and you sort of like a zipper that it closes the abdomen sequentially. As it gets tighter, it gets easier and easier to close. And I would just say, like, maybe one of the best data supporting primary closure as opposed to putting a mesh inlay is the study is a big prospective observational study of patients with open abdomens done by the AAST, and you can see here that the fistula rate for a primary closure is much lower than the fistula rate for a non-primary closure using a mesh inlay. So for this reason, I always favor a primary closure. This may seem obvious, but this is the evidence that always runs through my mind whenever I think about trying to get somebody closed. Get them closed if you can, and if you can't, then I'll lean on like an absorbable type of mesh. So talk about each of these: the short-term absorbable meshes and biologic and biosynthetic meshes. So my go-to is a short-term absorbable mesh. There are 2 types available: Dexon or Vicryl. Both of these are reabsorbed usually in 60 to 90 days. And you can place this mesh right on the bowel. We don't think this is fistulogenic, and I'll talk about how we do that. This is so like Luciano said, I've seen this before. I just say this to condemn it. If you put Vicryl mesh in, or any kind of a mesh as an inlay for the abdomen you can't get closed, you have to sew this mesh to the edges of the fascia. You can't just set it in there and hope that it works. It has to be sewn to the edges of the fascia. So and how we do this is we put a big piece of Vicryl mesh in, and I put 4 stitches in. I put 2 at the top, I put 2 at the bottom, and I run them out laterally and then tie them out laterally. And that's all you need. You can use a running PDS or a running Vicryl, some kind of absorbable suture is all you need. And some people like to fold the mesh up. You don't, but I don't think you necessarily have to do that. Just get mesh to fascia with a running suture, and that's literally all you need to do. And it's a pretty easy technique. The other thing, like Luciano said, is that getting skin closure here in this situation is critical. And I know you can't always, but do everything you can, even if it's really tight, get the skin closed. And we close over, so put drains in over the Vicryl mesh, and then I close the skin with interrupted nylon sutures. And I do everything I can, like I said, to get the skin closed, because I think the skin is not closed. That's what becomes a problem, and that is what sets you up for the fistula down the road. So this is what it looks like after closure over Vicryl mesh and drains. I think the drains are also important. Like I said, we don't think this is fistulogenic. This is a little bit of data from Cleveland Clinic. We looked at all these patients who had a Vicryl mesh inlay, and there were a lot of different circumstances here, right? Most of these were urgent cases. A lot of them were contaminated or dirty cases. 15% of these patients had an open abdomen. You can see our fistula rate down here is 8%. A lot of the 75% of these patients had an anastomosis, and I don't know whether they were like colon anastomoses or small bowel, but this fistula rate to me seems acceptable in the setting of contaminated emergency cases with anastomoses. So the way I interpret this data is that vicryl mesh is really not any more fistulogenic than any kind of other mesh. And I think that if you can't get the abdomen closed, it is my go-to. For one thing, it's a lot cheaper than biologic mesh or biosynthetic mesh, and we don't have any evidence indicating that it's any less safe. So we'll just talk briefly about your other options to use as an inlay here. I've seen this done both biologic or biosynthetic mesh. Just to remind you, biologic mesh is an acellular collagen matrix. It's derived from human or animal tissue, and then it's sort of classified according to its source. But biologic mesh, just want to emphasize this, is a permanent mesh. So if you're putting this in and thinking that it's going to get reabsorbed, that is not the case. Biologic mesh is a permanent mesh. Biosynthetic mesh, on the other hand, is a resorbable mesh. And there are two biosynthetic meshes available in the United States: BioA, which is absorbed in about 6 months, and then Phasix, which is a longer-term absorbable mesh. It's resorbed in 12 to 18 months. So you can use these biologic or biosynthetic meshes as an inlay. You can also sew them to the fascial edges, just like I sew vicryl mesh into the fascial edges. I will say, though, just to be totally clear, doing this type of inlay repair is not like this is a planning of ventral hernia. This is not like a definitive repair. This is an older study. But if you do this, if you sew a biologic mesh as an inlay, this is like a guaranteed recurrence, which is totally fine. Just want to be totally clear about this. This is not like sewing a biologic mesh in is not like going to prevent a hernia, as opposed to sewing a vicryl mesh in. So in my mind, this is using a biologic or biosynthetic mesh as an inlay is just planning a ventral hernia for later on. I just want to bring up one more thing here. So if you look at the World Emergency Surgery Guidelines, they do recommend using biologic mesh as an inlay in these situations if you can't get the abdomen closed, which I do think is totally fine. One thing I'll say here is that they also recommend putting negative pressure, like a wound vac, on the biologic mesh. And this is just purely anecdotal. I don't have evidence to support this, but I don't think that's a great idea. We prefer in our practice to put like wet to dry dressings on the vicryl mesh if you cannot get the skin closed. And here's a photo of a patient who had vicryl mesh, didn't have enough soft tissue to get this skin closed over the vicryl mesh. And so here is where we use a wet to dry dressing instead of a wound vac. I just think that putting negative pressure on in these situations, I've definitely seen like a biologic mesh is an inlay, wound vac goes on, and this patient gets a fistula. So just because you have biologic mesh there is not, and then you put a wound vac on, it does not mean you're going to prevent a fistula. So in these situations, I don't like the idea of negative pressure like over this mesh, especially a vicryl mesh, because the way that this granulates, the way that mesh granulates in, is that it actually granulates from the bowel through the mesh, and so I don't like any negative pressure on that mesh as this granulation tissue is forming. I just prefer to use wet to dries if you absolutely have to. But another thing here, like do not let the mesh desiccate. Do not let the mesh dry out. It is critical to keep it moist, because otherwise I think that also is a time when you can get it set up for a fistula. So get the skin closed, avoid wound vacs, and wet to dry dressings if you can't get the skin closed. And just to kind of reinforce what Luciano said, it's totally okay to plan for a ventral hernia in these situations. I think it's like unless like the day is perfect and I have plenty of time and resources, I will almost never ever do a TAR type repair in an emergency situation. Just get these patients off the table, save their bowel, save their skin, come back at another time to do a TAR or something more definitive. I always try to get the skin closed over my primary closure or my mesh inlay, wet to dry dressings if I can't get it closed. And then again, I don't think there's really ever a point that you should be using myofascial releases to get somebody's abdomen closed in an emergency situation. Okay, that's all I have here for my quick talk. So let's kind of go. We'll do like a quick Q&A for a few minutes, and then we'll switch to discussing some cases. So I saw a couple questions pop up in the chat as we were going along. And my first question is for you, Anna. You talked a lot about kind of, I think, elective-based parastomal hernia repairs. And if you had to, an emergency situation, what is kind of your go-to peristomal hernia repair?
So for me, we do some of these cases combined with the colorectal surgeons. It depends on the extent of the contamination. So in these cases would be the only time, if there is gross spillage, would be the only time where I would consider just a primary repair, approximating the fascia and the hernia. If there is contamination, but not like gross contamination, then my approach would be to use a phase 6 mesh.
And where exactly are you putting the mesh in? What kind of mesh-based repair will you do?
I would still try to do a sugar baker.
Is it like an intraperitoneal sugar baker?
Mm-hmm. Yes,
Okay.
intraperitoneal.
Okay, gotcha. So like a classic type sugar baker with a coated phase 6 mesh.
Yes, we use the coated phase 6 mesh, and I use the Pro Tack to tack it to the
Okay.
abdominal wall.
Okay, gotcha. Okay. What Luciano, do you in a like a emergency peristomal situation, what's kind of your go-to technique?
I think most of the time for an emergency presentation, I will stage that and I will just close it primarily expecting that it's going to come back. If it's a small peristomal, not associated with a concurrent midline defect, and I have a perfect situation, no intraperitoneal contamination, then my go-to would be a laparoscopic intraperitoneal sugar baker. Again, with a medium weight macroporous polypropylene with an anti-adhesive barrier, and using absorbable tackers for mesh fixation. But most of the time, that would be in an emergency setting, a primary repair.
Yeah, okay. I mean, we have like some different opinions here, which I think is great. Usually in an emergency situation, my go-to is also to just do a primary repair. I don't ever do a primary repair like in an elective type situation because, like Anna, like you said, it's not a durable thing, and we accept that. But to just save bowel, especially if this is like in the middle of the night, right? Like I am not going to do anything fancy.
Yes.
It is totally fine to just like reduce the bowel, close the hernia with some sutures, and then move on and fix it with a more durable repair when they recur.
Right.
So and if even during the day it's like I'm equipped to do a primary repair because if you're on call, there's like a lot of cases backing up during the day, or perhaps the bowel is threatened in this peristomal hernia, and so I don't think it's ever it's not a failure, like we heard, it's not a failure to do a primary repair in these situations and come back at a later date to stage these peristomal hernia repairs too. I think is a totally reasonable thing to do. That said, if you have the time and the expertise, and it seems like the sun is shining, it's a great day to do it. Like I have definitely done and more advanced techniques for peristomal hernias when they're like acutely obstructed. So we can kind of dig in a little bit deeper maybe during some of the cases. So someone I've seen 2 comments now about Dynamesh. I'm not sure what Dynamesh. Anna, do you use Dynamesh?
No, I was actually going to respond to that. I'm not familiar with it. I have never used it.
Okay, Luciano, do you use Dynamesh?
No.
Okay, I'm not sure what Dynamesh is either. And if you find out, you can let us know. So, so I guess my question for you, Luciano, we may get to this in the cases too, but like, what sort of helps you determine? Is it like, to go ahead and do a definitive repair? If you're gonna do a definitive repair in an emergency setting, like sort of help me understand like where you are, what time it is, like what the patient looks like, what is the ideal situation in which you're going to do a repair, not staged, but do a durable kind of complex repair in an emergency scenario.
Okay, I think that this decision making often starts before I get into the OR. Because you already examine the patient, you know how sick the patient is, you look at the CAT scan, where there is any concerns about dead bowel, about intraperitoneal contamination. So if I'm looking at a sick patient with a complex defect, I'm already going to the OR with having a stage repair in mind. And I think I go to the OR with that mindset. I am here to resolve the obstruction. I'm here to save the bowel. I am here to take this patient out of this acute problem. And if I can provide with a durable repair, that's great, but all those factors need to align, and I got to consider exactly in which environment I am. So we are practicing hernia surgery as most of what we do. I think it's a kind of a different situation, and we are doing complex procedures every day. So the level of comfort might be a little different. But most of the time, I go to the OR with the mindset that I'm there to resolve the obstruction and save the bowel versus then providing a durable repair. With that being said, I think it's still fair to provide the patient with a more complex procedure in case there is no gross contamination. In case I think that I can close the abdomen, the use of a myofascial release, the patient is not sick. The adhesiolysis was not very difficult, meaning I didn't have a bunch of serosal tears or enterotomies, which I might be concerned with whether they're gonna leak over the next couple of days. Because I think one of the worst things that can happen is you have a difficult adhesiolysis, you have a couple of serosal tears that you repair, you do a very complex procedure, and the patient needs to be taken back to the OR because, for example, a leak, right? So again, clean field, not sick patient. I can't close the defect comfortably. I have the skill set to perform a more complex procedure. And the other thing that sometimes we discuss is not going to be any more easy, the procedure the next time. I'm already here. I don't have 5 other cases to do right after this one, which was going to put other patients in jeopardy in case I spend 7 hours to do this case versus 2 hours. So that's what we would usually take to take the patient out of Dodge. I think those are the factors that I have in mind on my decision making.
Okay, great. All right, Steve, do you mind, or Tim, do you mind bringing up the cases?
Thank you, Ajita, for the information about the Dynam mesh. And it seems also that there is one that already comes with the keyhole pre-made. So maybe that's why they use it a lot for parastomal hernia. So
Sounds like it's not limited availability in the United States. Okay, Dr. Pena, this is your case. Maybe you can walk us through it, and we'll, give you our input.
yeah, so this one was a 61-year-old female, BMI of 21, had a total colectomy with an ileostomy, no prior obstruction, but in this case was presenting with consistent pain and problems pouching the ostomy. This was like an elective repair, wasn't an emergency case that presented. And then she had this parastomal hernia. So
she's not, she's a young woman, had everything looks like it was done MIS, right?
yes,
Was it open or minimally invasive?
minimally invasive.
Okay, gotcha. And you can see she has a parastomal hernia there, not huge, but definitely caused symptoms. So this is
Significant
like an elective.
discomfort.
Okay. How would you, so even, I mean, this could essentially present, I think I have a case later on to a similar presentation, MIS, a patient with, laparoscopic total colectomy for UC, but he's presented with a bowel obstruction. So, I guess like Luciano, if this patient presented during the day, hernia like this with a bowel obstruction, how would you approach this? What are you thinking about as you approach it?
I think if I'm planning for an MIS approach, meaning the patient is not very distended, I think I can get in there laparoscopically. I would try to manage this laparoscopically if I can. So insufflate the abdomen, see if I can reduce that incarcerated bowel in there. The defect is pretty small. I don't think the ostomy needs to be taken down or recited or anything like that. So if I am able, without any difficulty, to reduce the intra-abdominal, the bowel into the intra-abdominal position again, I think it's fair to do a laparoscopic sugar baker with intraperitoneal mesh, where ultimately all I'll have to do is to lateralize that bowel after closing the defect lateral to it with transfascial sutures and using a piece of mesh. If the patient is distended, if the patient is sick, I would probably not do that. I would go through a midline approach, reduce the bowel, examine the bowel viability, and proceed with probably a primary repair in this scenario.
Yeah, I think I agree. There's like no when you are thinking about like laparoscopic versus open approaches, what are the if this is like an elective scenario, what are the kinds of things that you take into consideration whether or not you can do it MIS versus you have to do it open?
So for me, it depends, like Luciano mentioned, if the patient is coming obstructed, and in that case, very distended, that I think I won't have enough intra-abdominal room for a minimally invasive approach. Or if the patient has extensive abdominal surgeries, open surgeries, where I think a minimally invasive approach would be very complex and very difficult to achieve. Sometimes in those cases, I still try and at least try to put a scope in there and take a look. Sometimes we're surprised, and patients that we expect to have extensive adhesions, we go in there and the adhesions are not that bad. And sometimes we go in there thinking there won't be that many adhesions, and we find disasters. So but if the patient is not obstructed, not severely distended, hemodynamically stable, and I have the time, I would definitely try for a minimal invasive approach.
Yeah, I agree. I totally agree with all those comments about like the distended bowel, difficulty doing an MIS approach, multiple abdominal operations, same thing. I would just say one other thing I think about is whether or not they have a midline component as well. And I usually I save like an MIS sugar baker type approach for someone who's had everything done lap prior, and they don't have a midline defect, and they just had to have a defect isolated to the around the stoma, is when I prefer to use a laparoscopic or robotic sugar baker type technique here. So, okay, that's great. Anything else to add for this case? Awesome. Let's go to the next one.
So this one is a patient, 64-year-old male, history of complicated diverticulitis, had a total colectomy with an anegliostomy, and that developed a hernia, had a prior hernia repair with mesh in a keyhole configuration. Now that case was the mesh that was placed was a phase 6 mesh, because at that time the patient also had like an infected groin mesh, so it was a contaminated case. So the decision was to place a phase 6 mesh. And then the patient had a recurrence about a year and a half later. And this is the CT scan with the recurrence.
Okay.
And the patient was having recurrent obstructive symptoms.
Okay, gotcha. Okay. Luciano, any thoughts here?
Well, it's a large parastomal hernia with a concurrent midline defect, a multiply reoperative field. I think in my hands, I would do this open through a midline incision. It looks like the small bowel is exteriorized through the left side. So I would have this patient see an ostomy nurse to get markings. And I would go for that with the plan to reside that ostomy towards the right side, in a more natural location for the bowel to be sterilized. So midline incision, extensive lines of adhesions, take down the ostomy from the left side with the plan to move to the right side. And in this scenario, I would do a posterior component separation with place of macroporous permanent synthetic mesh in the retromuscular position. In this scenario, there's different configurations that you can do when you're having a retromuscular mesh. You can do what we call cruciate incision, and bringing the bowel as a straight through the mesh through the rectus muscle and exteriorize it, or deliver the bowel into the retromuscular space, lateralizing on top of that mesh, and as a retromuscular sugar baking configuration, which probably would be my option in this scenario.
Yeah, I agree. In an elective situation, I totally agree with you. I would do this. There's a midline defect here, multiply reoperative. I would do this open with like a mesh-based repair. If this was an emergency situation, what would you do? like bowel, like Luciano, what would you do? Would you think like this is like patient comes in incarcerated? Would you, you know, would you like swing for the fences there and try to do everything, or would you, or what would
I,
you make? How would you?
I think
Decision?
I think I probably would. And in an emergency presentation, I have two large defects, a multiply reoperative abdomen. I think probably I would take this ostomy down. I would recite it towards the right side, and I would close the midline and the peristomal defects primarily. And whenever those hernias recur, I would come back for a formal reconstruction and potentially already reinforcing with mesh the current ostomy prophylactically in case the patient has not developed a parastomal hernia into my new location.
What'd you guys do, Anna?
So in this case, actually, we went in laparoscopically. There were extensive adhesions, but we took them down. There was more like omentum and not necessarily bowel. So we took them down laparoscopically, reduced the bowel. There was still evidence of the previous mesh that was placed in the keyhole configuration. So after reducing the bowel completely, we approximated the fascia using Stratafix suture, so laparoscopically closed the defect, and then we placed a Bariatric DS, the coated mesh in a keyhole configuration as well, but opposite to the direction that the previous mesh had been placed.
How's you do? How are they doing? How's he doing? So far,
Patient
so
is doing good. So far, so good.
Okay, great. In what situation would you like, what would make you, recite in an emergency situation? What would make you think about reciting the ostomy?
So I mean, I think if I cannot, I mean, if in this case, if I can still get the mesh in a retromuscular, well, but here is a big defect. So I think if I were to do this case open with a big midline laparotomy, I agree with Luciano. I would try to relocate that stoma to the other side, getting ready to come back later to repair probably both the incisional hernia at the prior ostomy site as well as a new parastomal hernia.
Anything, Luciano, that makes you want to recite this thing in an emergency situation?
I think this, if the peristomal hernia is very large, I would probably thinking about reciting because I don't think I'm going to be able to narrow it down around the ostomy sufficiently to prevent like a early reherniation. And I will talk to the patient as well as like how much they like or how much they hate the position where the ostomy currently is.
Got it. I would say someone asked a question about doing these robotically rather than laparoscopically. Do you think that that's easier, Anna?
I think definitely robotics makes the dissection of and taking down of all of those adhesions much easier, and it also allows for better suturing. So definitely, yeah, if I have the robot available, I would do it with the robot too. It all depends on whether we have
Yeah,
it available at that time or not.
totally. I agree with you. I like to do these like IPOM sugar bakers robotically. I think it is a little easier to do it robotically than laparoscopically. But again, it depends, in an emergency situation, often the robot is not available. And so we'll do them laparoscopically in those situations. Okay. All right. So let's go on to the next case. When someone asks you how long those cases are, if it's a primary repair, I'd say 2 hours. If I'm doing some kind of open retromuscular repair, I'd say probably 3 to 4 hours. And if it's not like a minimally invasive IPOM sugar baker, I'd probably say a couple hours. Okay, all right, Luciano, what you got for us here?
So this is a case where I'm going to try to illustrate exactly what the blue sky mean and why I decided to do what I did on that patient. So it's a mid-50s female. At the time she presented with an obstruction, her BMI was 46. This is like a recurrent infraumbilical midline hernia. I don't know, Ben, if they can put this
I think
CT
Steve
scan.
can run the video.
But it's an infraumbilical midline hernia, has a history of a couple C-sections and an open epi. presented with a recurrent small bowel obstruction on the hernia. On this presentation was about 3 weeks after her last presentation. As we can see here, there is a transition point at the level of the hernia, some fluid on the hernia sac. She was not sick, normal white count, lactic acid of 0.7, no peritoneal signs on physical exam, but definitely obstructed.
Okay, so you're telling us you swung for the fences on this one, no base hits?
That's right. Yes.
Okay.
So it's curious. This patient was already seen by a couple of other surgeons that told her to lose weight before a definitive repair. She was never able to do so, ended up presenting with obstructions. This patient to me looked a good case that I could try to provide her with formal reconstruction at that time. So there's a video that we can show after. Adhesiolysis was not difficult. Bowel was not very distended. The defect was about 10 centimeters wide. I ended up doing a posterior component separation using a medium weight macroporous polypropylene in the retromuscular position. I think they can click the video here. Yeah. Ultimately, this one went well. She was in the hospital for about 6 days post-operatively. I just recently saw her for a 6-month follow-up with still no wound complications and no hernia recurrence, meaning this to me was the perfect situation where I could do this. This was at 9 in the morning. There was no difficulty. I had good help. I'm used to do this operation in an elective setting. The bowel looked okay. There was no difficult adhesiolysis. End up being the situation where I think this was appropriate.
So you had the time, the resources, the expertise, the patient was stable, and so everything was, everything lined up, and so you went ahead and hit a home run here. The
That's
full
right.
shebang. Did the
That's
full
right.
shebang. Okay.
Unfortunately, yes.
Okay. All right. And any thoughts there?
It just the moment I heard 3 weeks after the prior repair, that was like I figured the tissues were gonna be. It's not like the
Sorry,
best.
3 weeks. Sorry, I think I said it wrong. She presented 3 weeks ago with an obstruction, was
Okay.
managed non-operatively, and was
Okay.
presenting again with obstruction 3 weeks after. So it was not
Okay.
a prior repair 3 weeks ago. Yeah.
Good. No, that's better,
Okay.
because I thought, oh my God, 3 weeks later, that must be, everything must be bad there, plaster.
No.
No,
I would
I
be
think
fired. I would be fired from this talk if I did that.
in this case, I would have probably just done an open and try to do a primary closure or bridging mesh and close the skin over.
Yeah, I think it's also totally reasonable. Either approach, totally reasonable. This when you asked a question there, Luciano, I think did you leave the how did you close the fascia here? What did you do with the mesh? Did you fixate the mesh or anything like that, or how did you close the fascia?
Yeah, I closed with interrupted figure of eights exactly as I showed on those slides. I do not fixate the mesh. The mesh is placed in a diamond configuration in the retromuscular space. I think that it has been a change in our practice over the years by not doing routine transfascial suture fixation anymore.
Okay, yeah, I do the same thing. All right, let's go to the next case. We have about 15 minutes left.
Okay, there's another case of mine, patient in his high 70s with BMI of 23, history of subtotal colectomy with an endoleostomy due to ischemic colon. He presented with abdominal pain, nausea, vomiting, no output from the ileostomy for the past 4 days. On presentation, ill appearing, white count of 26, a lactic acid of 5.4, and this was his CAT scan at presentation. We see here an isolated defect on the ostomy with some fecalization. It looks to me a little bit of pneumatosis also on the small bowel that was incarcerated into that parastomal defect. No concurrent midline defect.
Yeah, what do you think?
Ben? What would you do, Ben?
What do I do? Yeah. So I think this patient is like not doing. He's got white count of 26, his elevated lactate. I would do this through a midline incision. No questions. Just open this patient up. Try to reduce. I imagine this bowel might be difficult to reduce from the stoma, and so if that's the case, I wouldn't hesitate to actually just enlarge the stoma defect to be able to reduce this bowel and get a good look at it, and then, if I had to do a bowel resection, I'd do a bowel resection, or if I had to resect the bowel and bring up a new ostomy, it's all totally doable through an open incision. And then given how sick this patient is, I wouldn't do anything fancy here. And their age, I would just, close primarily and come back another day if it recurs and they're symptomatic, and fix it at a later date.
What do you think, Anna?
Yeah, no, I agree. Given the presentation, I would suspect part of that bowel is going to be ischemic and I'm going to have to resect it. So I would also do it open and try to reduce it, and, resect it if I have to resect it. And I wouldn't be placing a mesh here. I would just approximate it primarily, close the midline, and leave it for another day.
Yeah, I went through the midline as well. The strangulated bowel was like grossly necrotic. It was very edematous. I had even difficulty of reducing that from the abdomen. So I made a counter incision around the ostomy, took it down, resect that bowel. The peristomal defect per se was not very big, so I exteriorized the bowel through the same hole and did a primary repair around it. Patient was like for several weeks on the ICU, like still sick with septic shock and respiratory complications. Ultimately did well. I think it's a near out, and I saw already a CAT scan that was done for other reasons. I think for kidney stones or something like that, and this has not recurred as of now. We're still waiting for the recurrence.
Primary repair wins.
Yeah.
You never know, right? You never know. Okay, love it. All right, let's go to the next one, Steve. Okay, here's one of my cases. This is right, a couple things to think about here. So 65-year-old male, his BMI is 56. He's had prior laparotomies. He had a prior laparotomy for a strangulated hernia and had a bowel resection. And so he comes back again and he's got another bowel obstruction in this. He's got an incarcerated hernia with a bowel obstruction. So, but he's like not on pressors. He's doing fine. What do you guys think about this situation? Luciano, let's go to you first.
I think same thing as we previously discussed. I do anticipate that he's going to have difficult adhesions. He's chronically obstructed. I'm already going with the mindset that I'm going in there to save the bowel and to provide this patient with stable soft tissue closure. At a BMI of 56, I think it would be probably a little bit of a stretch to try to do formal reconstruction at the same time. It's a very unoptimized patient. But ultimately, I think the local conditions and all those other variables should be considered when I'm going in there. So if I go in there, I don't have to resect that bowel. There's no gross contamination. The patient is not sick. Visualizes was not very difficult. And I do feel that my local conditions and my expertise is available. I have good help. I'll probably do a retromuscular repair. But most likely, I think this would be the patient that I would just go in there, close primarily. If I can't, I bridge with vicral mesh, close that stuff over drains, and provide him with a good skin and soft tissue closure as well.
Anything different, Anna?
No, I agree. Probably in my case, that would be my approach. I think also depends what time of the day this patient is presenting to, and like Luciano said, what help is available. But most likely just a midline laparotomy, lysis of adhesions, reducing that bowel, and trying to close that abdomen primarily, or bridging.
So this is a great. So this brings up the next question. How do you know whether to whether it's under too much tension when you close it primarily, when you should back off a little bit and put a vicral mesh inlay in there, or how do you assess that? How do you make that decision in the OR whether to try to close them all the way or to just do a vicral mesh inlay?
I think
I
we
always,
do. Sorry, go ahead. Go ahead.
no, go, Luciano.
I think we use some parameters in the OR to really determine how high those pressures are changing during the facial closure. I think we do that all the time when we're doing TARs and we're closing people very tight. And I think the same concept applies when I'm closing people's fascia in an emergency setting, even if I did not do a component separation. So before I start closing the fascia, I ask anesthesia to measure their plateau pressures so I can establish what the baseline is. And I start putting my figure of 8 stitches and I start tying. And before I really tie the last 4 stitches right on the center, I ask them to measure the plateau pressures again. And also there is the visual appearance of like how much the bowel is poking through those edges of the fascia that are still not closed. If the plateau pressures go up for more than 6, usually that's a sign that this patient is going to be tied. There might be a component of transient intra-abdominal hypertension. The sicker the patient is, I'm going to be more likely to keep him intubated and go to the ICU after that. It does not necessarily change whether I would still close him primarily or whether I would just bridge with a vicro mesh, but we'd also tailor what is going to be necessary during the immediate post-operative care for this patient. If I'm closing them very tight and plateau pressures are going up, I'm sending this patient intubated to the ICU.
Do you, Anna, how do you assess like does the quality of the tissue factor into your decision making?
Definitely, if I have good fascia, like good fascia edge, which is not most of the cases, then I'm more comfortable leaving it a little bit tighter. But if the tissue is not the best, then I will feel more comfortable doing the bridging if I am very suspicious that there is a tension. I do ask for the plateau pressures as well. And I would, if there is a high increase in the plateau pressures, I would definitely feel more inclined to bridging it. We here, I don't do, I like your technique about doing the multiple interrupted figures of 8. I think I'm going to start trying that because I just ask for the pressure before starting to close and then at the end already. So
It's a good technique. It's like if there's one technique that we want to share with people, I think it's that one. It works amazingly well to get people closed. Yeah. All right, so let's go to the next slide. So a few days later, this patient had a gush of fluid from their incision, and they were worried about a fascial dehiscence, so they got a CT scan, and sure enough, there was a little fascial dehiscence. So they took him back to the OR. And go ahead one more, Steve. Because that patient was closed. That patient was closed primarily, I should say. A patient closed primarily, not micromesh, and then they added dehiscence. And so I think, and then they went back and put a micromesh inlay here. And I think this brings up the fact that like these decisions are hard, right? Like whether to close primarily or to put a micromesh in a patient with a high BMI, multiply recurrent hernia. These decisions are hard to make. We don't have like a tool or some objective evidence we can use in the OR to say, oh, this fascia is like there's too much tension on this fascia, or the quality of this tissue is too poor. And so in the year 2026, we just have to rely on our judgment a lot, and it can be a difficult call to make whether to close in primarily or to use micro mesh. So these are just some of our experience here. Any other thoughts about this, Luciano or Anna?
No, completely agree. Those are very hard. Those are very hard decisions. And it is just a consequence of managing and taking care of those complex patients. Sometimes that's going to happen. You just got to make the right decision of taking them back to the OR and doing something different the second time.
Yeah, totally agree. And I agree with you. I don't think that that I would have done a TAR in this situation. That hopefully try to optimize their BMI and come back do a TAR later on. Someone asked about peak pressures here. We actually use plateau pressures. Plateau pressures in some retrospective data have been found to be a better surrogate of intra-abdominal pressure as opposed to peak pressure. So we use plateaus. And sort of again, older kind of retrospective studies have shown that our threshold is sort of about 6 millimeters of mercury. If the delta in their plateau is over 6, then we tend to, between when they're open and when their anterior fascia is closed, if it's over 6, then we tend to leave them intubated for that first night and then check their plateaus the next day. And the myofascial releases, we don't understand this well, but they tend to gain some compliance to their abdominal wall over the 24 to 48 hours after surgery, and often you can get them extubated safely at that point. So this is not based on prospective data, it's retrospective data, but it's kind of the best that we have. Okay, let's do one more quick case. This is a patient who came in a couple weeks ago here to our EGS service, 72-year-old lady. Her BMI is 38. She had some history of a back surgery. We're not totally sure, but she presented with a gastric outlet obstruction here through this flank hernia. Steve, can you go to the next slide? I kind of put a couple of representative CT scan images in here. So, and then maybe one more. Okay, so all right, Anna, what do you think about this flank hernia?
Oh, that's a tough one. This is so the patient had any other besides the back surgery, on any other surgeries?
Not that we know of.
No. So I think just for the repair itself, this is one where I would love to be able to do it with a robot and be able to reduce that if it's reducible. If I can reduce it, then I would be able to create my flap of peritoneum and then place a big mesh there to cover that, because it's so lateral that I feel like you're not going to have anything to close that defect. You won't be able to close it probably.
What do you think, Luciano? Would you swing for the fences here, or do or base hit?
I would just be very, very traditional here. I would just do this open. I think the robotic platform is great for flank hernias, lateral hernias. A preperitoneal approach is great, but I probably would not do this in an emergency situation here with this degree of the gastric distension and all that stuff.
How would you do this open? Would you how would you position the patient?
I couldn't see exactly the CAT scan through where the defect is. Is this like a true flank hernia, or this is like a defect through the linea semilinaris?
No, yeah, this is like a flank defect. There's no midline component.
I probably would just go through the midline.
Okay.
Yes.
And then what would you do once you're in there? Would you do like a preperitoneal repair like Anna described, or would you do like a vicral mesh, or what would you got in there? What would you do?
I think I would probably do if the conditions allow, I would probably do a unilateral TAR, getting retromuscular and then preperitoneal towards the lateral abdominal wall, extending my dissection all the way to the psoas so I can have enough overlap, and potentially limited retromuscular dissection towards the other side just for overlap, but not doing a TAR towards the contralateral side.
Okay. So I'll tell you what we did here. I wasn't actually involved in this case, but one of our esteemed colleagues, Dr. Capato, was involved in this case. I think he had a question about the robot earlier on. So what they did is they went through this was not a hernia. Hernia surgeon didn't tackle this case. It was one of our HPB colleagues, but he approached it through the midline, and then they reduced everything pretty easily. But then they're sort of left with this big lateral defect. And what they tried to do at first is close the defect primarily. But once they closed the lateral defect primarily, they actually had difficulty then closing the midline because there was so much tension laterally now. So they took out all the lateral sutures and actually put a piece of vicral mesh, sort of like just across the defect, bridged it with a vicral mesh, and then closed the midline. And they were sort of able to get a base hit in this situation, resolve the gastric outlet obstruction, and just plan for another hernia in the future, which is again like totally appropriate. I had this come to me, this may have been one where I would have tried to hit a home run here and position the patient in the left lateral decubitus position so her right side is up, and then make a big flank incision between ASIS and costal margin, and then do it like a unilateral TAR like you described on that one side. So, but I think again both are totally appropriate. So anyway, we're out of time. We have 1 minute left. Let's roll the last few slides. Thank you everyone for attending. I think this was great. I really love to see all your comments in here. I wish we had more time to answer more questions. I hope that this was helpful for you. And our next live from Cleveland Clinic is about solutions for urgent GI challenges. So we hope to see you there at our next live from Cleveland Clinic on September 9th. Same time, 6 to 7:15 Eastern time. And then don't forget, Updates in General Surgery is in Vail this year. It's January 22nd to 25th, and there's going to be tons of great content here. This is for general surgeons in academic practice, general surgeons in community practice, trainees, everyone, APPs, anyone involved in surgery at all. We welcome you to Vail in the winter of 2027. So we hope to see you there. All right. Thanks, everyone. Have a great night.